great to see you here. As Barbara said, I'm a movement disorder doctor. I've been doing this for 30 plus years. I'm going to show you some videos that take me way back to when we first started. I've tried to stay on top of the cutting edge of treatments and hope to present some of that to you today. Was a full professor of neurology at the Medical College of Wisconsin. As a movement disorder specialist, Parkinson's is the bulk of that practice. But anything having to do with tremors, a phenomenon called dystonia, dyskinesias, these are terms that you've probably heard and familiar with a little bit. And the reason I think it's important that you or that a person with Parkinson's or any movement disorder is seen and followed by a movement disorder specialist. Okay, so this is my business card. At the end, I'll have this up again, and so if anybody wants to get my numbers, feel free. I just saw this nice lady yesterday, and she kind of illustrates why I think it's important that a movement disorder doctor be involved. So this lady is just a fantastic 90-year-old. Okay, so this lady, she's 90 years old, has a 2-year history of tremor, was seen by a neurologist, a well-trained neurologist, in fact, who trained at one of the top institutions in the United States. You'd recognize the place. And she came to me because, well, he didn't do anything. He just said, you have tremors. And so I said, wait a minute, this is not just tremors. She has a little trouble getting up. As we watch her walk, we see that the right hand is shaking. The left hand is shaking, but there's an asymmetry. So one hand tremoring more than the other. And when I have her stop and now do something with her hands, like hold your hands out front and do what we call finger to nose testing, the tremor stops completely. This is textbook stuff for Parkinson's. And here she'd been told, you don't have Parkinson's, all you have is tremor. So anyway, so this nice lady had been told that it's just tremors, it's nothing more than that, nothing I can do for you. And this again by a neurologist trained at one of the top places. When I had her then talk with me a little bit, I don't know if you can hear.
That, my dear, is Parkinson's.
But what she has, just looking at the picture, she has facial masking, that we call hypomimia. Her voice is quite soft and quite low. That's a Parkinson type of voice. Okay, so anyway, so this lady comes to me. She's been blown off by the local person as it's just tremor, don't worry about it. And I come to see her, and she's got an asymmetric resting tremor. She's got facial masking. She's got vocal hypophonia, breathy softness of her voice. And this is Parkinson's. This is a textbook case of Parkinson's and should not have been missed by a qualified neurologist who trained at one of the best, et cetera, et cetera. And not that I'm any genius, because this doesn't take a genius to figure this out. And watching her walk was kind of the deciding thing for me.
Okay, say again. So, this.
Well, this is what started this whole thing all off. Dr. James Parkinson was a general practitioner. This little tome was published in 1817, and it's about about a 1/4 inch thick. It's a little book, you can read through it real quick. In it, he describes 6 patients on the streets of London. If you can imagine sort of David Copperfield, that kind of era London. And he spotted 6 people that he described, only 2 of whom he actually laid hands on. So Dr. Parkinson was a very astute observer, and in this little book, he describes everything that we now know as Parkinson's disease. Four features, only 2 of which you have to have. The 4 features are resting tremor. Second is cogwheel rigidity, which is a very particular type of resistance to movement when the examiner, me, when I do range of motion, I can feel it's like cogs in a gear. chunk, 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 chunk. That's a very unique Parkinson. So resting tremor, rigidity, bradykinesia, which is slowness of movement, and trouble with balance and walking. Now, you only need 2 of those 4 to qualify as Parkinson's. So many patients do not have that type of tremor. Like this lady happens to have it, so that kind of nails it. But in my experience has been that between 1/3 and 1/2 of patients with Parkinson's disease do not shake at all. And that is a real topic of, is this thing out again? Yeah. And so he called it the shaking palsy. It wasn't until, this was 1817. It wasn't until roughly 1880 that a French physician named Dr. Charcot, very famous legend in the world of medicine and neurology, Dr. Charcot was the first to call it la maladie du Parkinson, or Parkinson's disease. That was in the 1880s. He practiced in a huge, crazy place called La Salpêtrière, which was kind of the Parisian catchment for all the things that people couldn't figure out, much of it psychiatric. But in any case, we've come to know this as Parkinson's disease. Okay, so moving right along. So now we have technologies which can help us to figure out if this is indeed Parkinson's disease. And one of those technologies is something called a DAT scan, or dopamine transporter scan, which some of you may have some experience with. With dopamine transporter scan, the area where dopamine is produced lights up, and this is normal, and over here you can see that the scan has lost much of that activity. So this I sometimes will employ, but usually if I can't figure it out within an hour of an examination visit, then that's unusual, to be quite honest. I mean, at this stage of the game, I'm pretty good at this, so I will sometimes get this when there is some element of I'm not sure, because there are things that can mimic Parkinson's disease. This brings us to the issue of dopamine and lack of dopamine production. Dopamine is produced deep in the back underneath in the upper brainstem, specifically an area called the substantia nigra, or black substance. And this would be an anatomic slice of the upper brainstem called the midbrain or mesencephalon. And these dark areas here, those are made up of thousands and thousands of little black dots. Each black dot is a brain cell, a neuron that makes dopamine. So this is normal, lots of dopamine being produced. And this is a patient who had Parkinson's. And you can see how it's bleached out. And if we look under the microscope, a normal brain in the substantia nigra, you've got these are those little black dots that are here. Now under a higher magnification, you can see these are nice, healthy, fat, dopamine-producing neurons. And here they're few and far between. It's bleached out. And when we look at an even higher magnification, we see this pink spheroid, or it's actually a Lewy body. And the Lewy body is the pathological hallmark of Parkinson's and some other things. And everybody's kind of heard of diffuse Lewy body disease. That's been a kind of relatively recent addition. But this is a Lewy body, and we now know that the Lewy body is made up of an abnormal protein called alpha-synuclein. And we're going to talk about alpha-synuclein in just a bit. Alpha-synuclein is there's normal alpha-synuclein and then there's misfolded alpha-synuclein. It's the misfolded alpha-synuclein that aggregates or clumps and aggregates into these Lewy body granules. Now, this is a very controversial area because we've been laboring under the idea that if we could just get rid of those Lewy bodies, we're going to cure Parkinson's disease. Well, it's not so easy, and I'm going to talk about that in just another minute. So the problem, not enough dopamine in the brain cells and substantia nigra are degenerating. Why? Honestly, we don't know. Genetics does play a role. Estimates are between 5 to 20% of cases of Parkinson's have a genetic component. I think it's 5% or less. That's just my personal observation. And I don't usually test for genetics. We'll talk about that in a minute, because it doesn't really make a difference unless it's in young onset Parkinson's. Now, Michael J. Fox is a good example of somebody with young onset Parkinson's. He was symptomatic age 29. I had a patient back when I was at the Medical College of Wisconsin who came down with Parkinson's in high school. So it happens. It's very rare. But there is such a thing as young adult onset or young onset Parkinson's. The other issue is with environment. What about exposures, things that, chemicals? I mean, let's face it, we're bathing in all kinds of environmental exposures, and it turns out that they do play a role. Let's talk about the genetics again real quick. We can test for all these different genetic aspects. I don't usually do that again, but more recently, one of those genetic component or aspects is called glucocerebrosidase. Now, glucocerebrosidase is an enzyme which is critical for integrity of cellular function. And if you have this particular gene mutation and you have 2 copies of it, then you're considered, we call that homozygous. And folks that are homozygous for this glucocerebrosidase gene, they have a condition called Gaucher's or Gaucher's disease. And Gaucher disease is a childhood disease that usually leads to early death. It's awful. It's a sort of a form of cerebral palsy. They have all kinds of developmental problems, but it turns out there is a carrier state where you don't develop Gaucher or Gaucher's disease, but you have a carrier state that does increase the risk of developing Parkinson's disease. And we now know that if you are a GBA, a glucocerebrosidase carrier, and if you do develop Parkinson's, it's earlier in onset and there's more cognitive involvement. And we now, on occasion, will, before doing DBS, for example, deep brain stimulation, we will test for this because the outcomes may not be as good as in folks who don't have this. Now, most people with Parkinson's, 99% do not have this kind of thing. But it's out there, you're going to see it, you're going to run into it. That's why I'm talking about it. Environmental factors, we've known for years that exposure to well, water, and agricultural work. Dr. Bronstein at the April symposium touched on some of this in the Central Valley. We've known that in fact, as a resident, I did my residency at Stanford, and one of my attendings, Bill Langston, he found a group of addicts who looked like they had the worst Parkinson's ever. And it turns out that their dope was contaminated by a chemical called MPTP. And this became a very, very significant research tool in the 70s, 80s, 90s, and so on. It still is one of the best models for Parkinson's. This is an excellent, excellent review article that I strongly recommend to any of you that are interested in really reading up on the latest in Parkinson's. This was in the August 1st issue of the New England Journal of Medicine. New England Journal, as some of you may know, is kind of the Bible of medical research. And the August 1st, so just last month, there was a wonderful review article. Dr. Tanner and Dr. Ostrom at UCSF. Carly Tanner has been a major researcher in the field, especially having to do with epidemiology of Parkinson's. And she and Dr. Ostrom wrote this wonderful review. So if you really want to take a look at a nice, succinct article that puts it all together, I highly recommend this article. And they talked about things like, what is Parkinson's, talking a little bit about the non-motor symptoms of Parkinson's, disorders of problems with mood and sleep, loss of the sense of smell, autonomic involvement like chronic constipation, REM sleep disorder, things that we now know may precede the development of the motor symptoms by years, even decades. Gene variants are causative in approximately 20%. I think it's less than that, but that's just me. No therapy has been proven to slow progression. We had high hopes back in the 80s for various things like Eldepril or Selegiline, and then it was Rasagiline, and everybody was all pumped up. Well, long story short, they don't work. Vitamin E was a big one. CoQ10, huge. Going to be the next big thing. Nothing has panned out as far as slowing the progression except one thing, and that's exercise. So we know that exercise, the more the merrier. I tell people to grab one of these, which is a pedometer. It's a step counter. It costs about $10. And if you can get your steps in, you know, that's the strongest positive thing you can do for yourself. This is talking a little bit about those occupational exposures. Some of the agricultural chemicals like the paraquat family, rotenone. We know everybody's probably seen commercials on TV for if you were a Marine stationed at Camp Lejeune, that call, you know, and it turns out that actually turned out to be legit. There's a chemical that they were exposed to called trichloroethylene, or TCE, which is an industrial solvent, and the Marines were they were told to use it on cleaning various pieces of equipment, and TCE, sure enough, is linked to Parkinson's disease. Other interesting factors, some of you who may have attended the April session, one of the speakers talked about dairy and how dairy was bad for you. And I kind of rolled my eyes. Well, it turns out that if you ingest industrial quantities of dairy products, you know, cows eat grass, and grass gets treated with herbicides. And so sure, there is some risk there. But as I walked out of that session, I was like, hey folks, enjoy your ice cream, you know, don't sweat it. So it's, I think, more theoretical than real. I have this slide up here, and these slides were taken from that article in the New England Journal, so if you want to get all the details. I have this one up because a decreased risk of Parkinson's disease has been associated with, of all things, cigarette smoking. Of all things, heavy caffeine consumption. And decreased risk with, I mean, this is the good sign, is the physical activity. Nobody has really figured out why it is that smokers are less likely to come down with Parkinson's. Is there a chemical in the product that is neuroprotective? Well, of course, the thing is they're dying from cancer and heart disease. So, you know, not a good option. And the same thing with caffeine consumption. These are epidemiologic studies that really don't have any bearing on you and you and you and you know. Now, this was just published a few days ago. I'm telling you, I'm trying to be right on top of this. So this was published September 5th in JAMA, the Journal of the American Medical Association. And they found in this large study, several thousand people, that folks who had upper GI mucosal injury, and this was determined by endoscopy, people that had gone to their doctor, my stomach hurts, I got belly pain, I got whatever, and they'd be sent for endoscopy, and those folks that had endoscopy done that showed upper GI mucosal damage have a higher rate, 76% greater risk of developing Parkinson's disease. Now, I found that mind-blowing because I happen to have a little bit of that, which I just think is from coffee. But mucosal damage was defined as presence of erosions, esophagitis, ulcer, or peptic injury. And this kind of led to a discussion of the gut theory of Parkinson's, the bottom up as opposed to the brain down. For all these years, we've been thinking that Parkinson's was primarily a brain problem that would then progress to involve lower aspects of the neuraxis, we call it, where a German pathologist by the name of Heiko Brock, and now we have something called Brock stage. He and his wife, neuropathologists, came up with this and have suggested that Parkinson's may actually begin in the gut with with ingestion of whatever chemical, and that then the damage is transmitted via the vagus nerve. Now, the vagus nerves are kind of the controller of almost all of our internal bodily functions. The vagus nerve controls your gut, your heart rate, blood pressure, lots of internal things that we don't think about, autonomic things, or automatic. The vagus nerve then is postulated to take this damage originating in the gut, whether it's stomach or small intestine, and transmitting it retrograde up to the brainstem. The vagus nerve originates in the lower brainstem, in the medulla. And it's postulated that it's actually Parkinson's is being pulled up, and then it hits the brainstem, and then we start to see the motor symptoms. So, misfolded alpha-synuclein can spread from the gastrointestinal tract to the brain via the vagus nerve, a neural superhighway. Well, it's a little bit of an exaggeration, but it's kind of an interesting theory, and we'll see if it pans out. Biomarkers, alpha-synuclein, we talked about that a little bit with respect to the Lewy body. And now we have a test that can measure your alpha-synuclein. It's called an alpha-synuclein seeding amplification assay. The bad news is you have to have it done with a lumbar puncture, a spinal tap. So not a lot of people are knocking on the door saying, would you please do a spinal tap on me? But it turns out that it's very sensitive and diagnostic for Parkinson's. However, the association of alpha-synuclein and Parkinson's does not mean causation. Association does not mean causation. And I will tell you a little story about a disorder called Alzheimer's disease. Alzheimer's is related to an abnormal protein, not alpha-synuclein, but something called amyloid or beta amyloid. And beta amyloid in Alzheimer's patients builds up in the brain. So the theory, and this is going back 10 or 20 years, was beta amyloid is the bad guy in Alzheimer's. Alpha-synuclein is the bad guy in Parkinson's. In Alzheimer's, we're going to give patients medications that will dissolve beta amyloid, and people are going to get better. Well, guess what? They introduced these medications in the past year or so. You may have seen it. Big deal, the Food and Drug, big deal. And yes, we now have medications that are given via an intravenous infusion. One of them is called lecanemab, and the other one's called donanemab. And these are agents that will dissolve amyloid. And you can see it on a brain scan. There's an amyloid brain scan. And you can see on the amyloid brain scan the before and the after, and the amyloid just gets dissolved. It goes away. Guess what? Patients did not get better. They did not get better. And yet, even as we speak right now, the drug companies, I tell you, I get stuff in the mail or email all the time. They are driving doctors to use these medications when they do not work. They don't help people. Well, the same thing happened with alpha-synuclein. They developed some agents, some chemicals, some medications that would reduce alpha-synuclein. Patients did not get better. So the jury is out on these things. I just bring them up because you're going to run into it. I want you to say you heard it here. We talked a little bit about it. So I think the jury's still out. I would not sign up for any of this stuff until more evidence is available. Okay, so these are our current available treatments. Everybody knows about carbidopa-levodopa and all these other things. Carbidopa-levodopa is still our best medication by far. It's got its dangers and pluses and minuses, but I think it's the gold standard. It's what works best. It's got some pluses and minuses. I don't hesitate to use other medications, but if I want to get my patient better, carbidopa-levodopa is still the best way to do it. Just approved last June is a new formulation called Crexont. I don't really know I I haven't tried it. I don't even know if it's something I can prescribe. It's basically a long-acting carbidopa-levodopa, very similar to Rytary, which some of you may have heard of or be on. And these are nice. They're nice to have. They do have their place. They're very expensive. Many insurances will not cover things that are brand name. So, I don't jump right to using medications that are going to cost you $500 a month unless they're demonstrably better than generic carbidopa-levodopa. We have the dopamine agonists. Agonist is a mimic. It does not get turned into dopamine. It is a chemical synthetic mimic of dopamine. And these are the pramipexole, ropinirole, rotigotine patch. Apoken is apomorphine. It's a different, I rarely ever use that. And then we have these medications that basically there are two pathways by which dopamine is degraded. And every chemical in your body goes through a metabolic cycle. It gets made, it gets destroyed, it gets gotten rid of. Everything goes through a biological cycle. Dopamine is no different. Dopamine is broken down or metabolized via two pathways. One is called COMT, or catechol-O-methyltransferase. The other is called MAOB, or monoamine oxidase type B. And we have these medications which are blockers of either COMT or MAOB. And these are your entacapone, opicapone, selegisine, relagiline, so on and so on and so on. So we have lots of secondary meds that we can use in addition to our primary medication, which in my mind is still generic carbidopa-levodopa. But under review currently, as we speak, in 2024, they're looking at what I think of as kind of Me Too drugs. They're not breakthroughs. The Me Too drugs are pumps. There are two types of pump. Subcutaneous under the skin pump. You may be familiar with insulin pumps for diabetics. Well, they have developing a subcutaneous skin pump for these different products, apomorphine or Apoken, subcutaneous continuous carbidopa-levodopa, subcutaneous continuous carbidopa-levodopa patch, a patch. So these are under development right this year and may have a role to play. I'm not all that excited about much. We know that over time, no matter what you use, the therapeutic window does narrow. So early on, there's sort of the honeymoon phase of Parkinson's where the meds work great and everything's fine and dandy. But then a year or two or whatever down the road, they don't last as long. So you have to use more frequent dosing or adding secondary med. You have to start manipulating. That's my job. And as time goes on, the therapeutic window can get much more narrow. Now, I printed this off from an article just recently, looking at what's in the research pipeline, and there's all kinds of stuff being looked at. There's phase 1, phase 2, phase 3 studies. Phase 1 are very small studies looking at safety. That is, are we going to kill you with this? So what they do is they recruit a dozen or two medical students and pay them $300 a week, and they give them this stuff. So okay, phase 1, we're not killing you, or side effects. Phase 2, 20 to 100 patients, early efficacy studies. Phase 3 are really the studies that involve larger numbers of patients. But you can see, look at all these different things that are being looked at. So there's a lot going on your behalf, on our behalf. Of these, there is one that I will be involved with testing soon called linrispodin. It is a non-dopamine medication which has shown some early promise. By the way, you can go to clinicaltrials.gov and you can see everything that's available for Parkinson's. And you can segregate by state or age or anything. So go to clinicaltrials.gov. Of course, the Michael J. Fox Foundation and the Parkinson Foundation, these are good, reliable sources. This is the study that I'm going to be involved with, a randomized, double-blind, placebo-controlled, multi-center study to assess the efficacy and safety of linrispodin as adjunctive therapy in the treatment of patients with Parkinson's with motor fluctuations. I'll be recruiting patients within the next couple of months, probably. I'm excited by this class of medications, and these are the GLP-1 glucagon-like peptide. These are the ones that are the Wegovy's, the weight loss. They were originally developed for diabetes. But lo and behold, it turns out that one of them, and there was a study in France, found that patients who were on one of these GLP-1 inhibitors, their Parkinson's after a year was not as bad. Seemed to have a neuroprotective effect. So this will be huge. And you know, this GLP-1 stuff is fascinating, and we're seeing it all the time now for weight loss and so on. Well, wouldn't it be great if you could take this and your Parkinson's wouldn't get worse? So that's something to keep your eyes out for. This particular one, lixisenatide, there's a whole bunch of them, but just be on the lookout for GLP-1 medication, agonists. Glucagon-like peptide 1 agonist for the treatment of diabetes has shown neuroprotective properties in Parkinson's. So that's pretty cool. And that's what I just told you. Okay, so now, when I was originally asked to speak here, it was on Parkinson. I was on DBS. I've been a DBS proponent for 20 plus years. And I think it's a way underused modality. If there is any such thing as hitting a reset button in Parkinson's, it's DBS. I do not do focused ultrasound. That is a lesioning procedure. We hear about focused ultrasound. Oh, ultrasound, that's great. It burns a hole in your brain. It focuses high intensity beams into a spot, and it's like taking a magnifying glass and burning the ant pile or the leaves on the ground. I mean, it focuses these down and it's a controlled stroke. So I'm not a fan of it. I'm sure it's got a place, just not with me. So my job as a neurologist is to exclude one of the Parkinson mimics. I mentioned some of those earlier. Normal pressure hydrocephalus, or NPH, vascular Parkinsonism, which is multiple strokes, conditions like progressive supranuclear palsy or multiple systems atrophy. These are Parkinson-like conditions, but they're not what I think of as Parkinson's disease, standard issue Parkinson's disease. For this procedure, there is no age limit. There is a set of criteria that we use to determine if a person is going to benefit from deep brain stimulation. Deep brain stimulation involves placing a spaghetti thickness, think of a strand of spaghetti, implanted right down to the spot where your Parkinson's is causing trouble. And when we hook it up to a battery, I don't know if we have any samples here, but it's like a heart pacemaker, same size, everything's under the skin, delivers a little bit of voltage to a very specific spot that I locate in the operating room with my neurosurgeon. So I'm in there guiding the placement. And yeah, this is actually, thank you, Jason. So this is the size of the battery. It's like getting smaller it's smaller all the time. Goes underneath your collarbone, and it's hooked up to this. I don't know if you can see it, but and at the end are these little silver tips, and they allow me to pick which are the active contacts. We make sure that a person does not have dementia. Most people with Parkinson's do not have dementia, but most people with Parkinson's may have something called MCI, or mild cognitive impairment. We test for all this stuff beforehand. MCI is okay. Being a little forgetful is okay. But we want to make sure that a person doesn't have actual dementia, which fortunately is not that common. I do something in the office called off-on testing. So I have patients come in 12 hours off of their Parkinson medications. So I want to see them at their worst motorically. I want to see their stiffness, their slowness, where they got tremor and so forth. So I do an off exam. what my patients come to experience is I do the same exam every time. It's called the Unified Parkinson's Disease Rating Scale. The UPDRS is a way that I can give a score. Every visit I'll give you a score, a number, and I can track that number over time. So what I do is I do the UPDRS exam off medications for 12 hours. And then I have them take their medications and maybe a little extra so it gets them into the on state. So we talk about off and on. So what I want to see is an improvement in their UPDRS score of at least 30%. I want to see them transition from not doing well to DOPA responsiveness. Now the thing about it is patients with Parkinson's, they may experience, they take their medication here and their next dose is here, medication kicks in and they're good for a while and then it wears off. And then it kicks in and they're good for a while and then it wears off. And they're on this kind of up and down thing. What DBS will do is think of your very best part of your day. It's going to give you more of good quality on time with less medications. We expect to reduce medications by half and sometimes by more than that. And I have patients who are taking no medications. That's not typical, and we don't talk about that as being an expectation, but it happens. Our targets in Parkinson's, we can choose between these different brain targets. This is an example of me in the operating room, and behind me is okay, so that's me, and I'm listening to the brain cell activity, and I'm looking at it on the computer interface, and I'm looking for particular patterns of activity that tell me exactly where we're located. Okay, this is the patient. He's awake. Now I'm turning on the device. And so at low stimulation, we have stopped his tremor. Now I can tell you that, again, many patients with Parkinson's don't have tremor. What I can feel in the exam as I turn on the device, I can feel if they've got rigidity, it melts, it goes away. I mean, it's just remarkable. If they've got impairment of fine motor skills, I see improvement. This is a gentleman who I've got a before and after, and he has had Parkinson's for 20 years or so, and this is him on this side here, before DBS. So getting up out of a chair, I don't know if any of you experienced that, but kind of having to rock yourself up. In this case, I had to actually help him up.
You think you're going to be on the wall? Can you give it a try?
He's going to need his cane.
A lot of gait and balance issues for this gentleman. He was taking something like 24 pills a day. So, really, quality of life was compromised. And this is him about a month post-DBS on no medications.
Okay. You want to go for a walk? Yeah.
Mr. Jerry Krieger is about 16 hours off medications, on only stimulation at this time.
Nice brisk walk, Jerry. Come on back.
Yeah, I mean, I don't know why this isn't being used more often. I don't know. It really should be. Forever.
We've got sarcoma samples. Bring it out.
Now this, I included this just last night for one reason only, and that is just to let you know, to show you, this has been available for quite some time. You can see, I recorded this in March of 1997. This technology is marvelous, and it's just underused. So this, I want you to keep a look at this guy's walking here. Okay, a little stutter step turning. Otherwise, you wouldn't say this. I mean, you'd walk by this guy in the grocery store and say, it looks fine to me. Now, he is, at this point in this video, he's 1 year out. Here he is the night before surgery. I went to the hospital and I did a video with him the night before surgery, April 1996.
How about, should I give you that rail or you want to try it?
And this is an example. He doesn't have much in the way of tremor, but a tremendous amount of rigidity, bradykinesia, impairment of movement, rolling over in bed, getting in and out of bed, all of those things. So just remember, a minute ago, the guy you saw walking, that's him, the night before surgery. So inability to get his gait started. I mean, all the stuff where can't pick up his feet and so on.
Not yet. I'll tell you. Ready, get set, go.
So, in the office we do rapid alternating movements, finger tapping, hand opening, closing, pronation, supination. And that's me like 80 years ago. So loss of spontaneous facial expression. I'm going to move on just because. Am I running out of time, Barbara? Or?
You have till 3:15, but we want to make sure we have plenty of time.
Yeah.
Go.
This is kind of interesting guy. He's got the phenomenon of dyskinesias. And I don't see anybody here, but dyskinesias are the Michael J. Fox, can't sit still. That's called chorea, or dyskinesias is the most common term and so this is him also the night before surgery. Involuntary wiggling, writhing, twisting, very debilitating. And here he is.
Okay, let's give you a minute or so and then bridge.
So on the right side, the upper panel, he's got a little bit of tremor. In the lower panel, we turned his battery. This is battery, hasn't been turned on yet. Here we turned his battery on and the tremor's gone. But in both panels, there's no dyskinesias at all. So.
Good. Okay, let's give.
Well, tremors are, the reason we have tremors on video is because you can see them. You can't see rigidity. So I could talk about the mechanism of action of DBS. I wrote a book chapter actually on the mechanism of action. suffice it to say that we don't really precisely know how and why it works, but it does work. One of the mechanisms of action of DBS has to do with, we call it the network model, which is Parkinson patients, if you listen to their brain cell activity, parts of the brain are locked in to a certain frequency spectrum. And it's called the beta band. And beta band refers to brain activity in the 15 to 30 hertz range. And what I'll show you is, this is an example of brain cell activity off of levodopa or off of dopamine. And this is a frequency analysis, and they have a high peak between 15 and 30 hertz. This is called beta band. In order for any of us to move, so actually if we're sitting and daydreaming, we may be in alpha or beta band. In order to move, the normal brain has to kick from those slower rhythms to gamma, which is over 60 hertz. So normal movement, gamma, you need gamma. Folks with Parkinson's are stuck in beta. This is off of what dopamine does is it allows their brain activity to shift from beta to gamma, which is 60 to 80. And it's that more rapid brain cell activity which allows us to move freely. You have to be able to do that. Dopamine does it, deep brain stimulation does it. So I think that's probably as good of a representation as any. They've actually developed, one of the companies that makes DBS equipment has developed a system that will sense when your brain activity is stuck in that beta band, and it delivers the DBS activity right then. It sounds neat and it's kind of fun, but it hasn't been proven to work any better than what we currently use, which is a constant level of very low voltage, and it just seems to smooth everything out, you know. But there's a lot of research. This has been replicated in numerous studies. This was one where they compared deep brain stimulation to best medical therapy, and the folks with DBS, quite simply, the outcome was, in this randomized controlled trial, deep brain stimulation was more effective than best medical therapy. Best medical therapy is what your doctor does his or her best with manipulating your drugs. It usually means more pills of one sort or another. But when they compared the folks that were optimized on medication versus folks on DBS, the DBS group did better and didn't need as many pills. And that's why the title of my talk is, When More Pills is Not the Answer. That's kind of the sum and substance of it. DBS won't help your memory. It won't help some of these other things, but it will help you move better. And that's me. And this is our spot over on De La Vina. And now we'll take some questions. Well, actually, it's sort of a glass ceiling. 80s is not an absolute. The oldest patient that I've been involved with that we did was 86. A guy who was a retired dentist. And so it's not an absolute. But if we're at 80 and above, we're just more careful. I mean, we're careful as it is. But I'm more likely to maybe play the devil's advocate and, you know.
What would be a contraindication?
Well, if I see more than just mild cognitive impairment, if I see MCI or mild cognitive impairment is kind of a broad range, and there's such a thing as mild cognitive impairment, moderate mild cognitive, and there's sort of like shades of gray. So if we're starting to shade more towards the iffy cognitively, that would be an 80-year-old that I would recommend against. Medicare does cover it. Yep, it's totally covered and has been for a long time. Yeah, this is what goes in. Our target is about the size of an almond. It's called the subthalamic nucleus. My job in the operating room is to find that target with great precision, sub-millimeter precision. When we find the target and we implant this into the target, this tracks underneath your skin down to the battery. And then I can turn the battery on and adjust it, and I can really tailor it to that particular individual's needs. Again, comparing it to focused ultrasound. Focused ultrasound, you get zapped, it's done. With this, I can adjust it. I can play with the settings. So what are the settings? It would be how much current. It would be, there are just different things I can do. There's current, there's pulse width, there's amplitude, pulse width, and frequency. I can pick which of these, you can't see them, but they're these 4 little tiny silver, actually platinum iridium bands. And you guys are welcome to take a look at this. I can pick which one or which ones are active. There's a lot of different manipulations I can play with to get it just right for that person.
Amazing.
Yeah.
Change the battery?
Batteries change about every 5 to 6 years, although we have rechargeables now that last like 15 years. So the battery technology, and this battery's about, when I first started doing this back in the late 90s, the battery was twice as big, and now it's like this big.
Where is that position?
It's positioned just like a heart pacemaker. It goes under your collarbone. It goes under your collarbone, about here. I'm sorry, I can hear you.
How do you program it?
It's Wi-Fi. Yep. Yep. Yeah.
Tell me, since Parkinson's.
Falling. It can be depressing. I think that the reason we have not gotten beyond where we're at now is we really still don't understand what causes Parkinson's. We've got little snippets, we've got genetics, some percentage, we've got some things in the environment, but we really don't understand why the vast majority of people with Parkinson's get Parkinson's and what that does to your brain, or what's going on.
After 130 years, you have?
Are there cases when DBS doesn't work? The answer is yes, and the reasons are twofold. Actually threefold. There are 3 reasons DBS doesn't work. The most important one probably is improper patient selection. So folks who come in, maybe they look like they've got some Parkinsonism, but they really don't. They have something. That's where it takes. That's why I say you need to be following with a movement disorder specialist. So improper diagnosis. So if I were to implant somebody who had a Parkinsonism or a Parkinsonian syndrome, it's not going to work. That's why it's important for me to be able to sort out right from the get-go, what do you have? Do you have Parkinson's disease or large P or small p Parkinsonism? And that's a whole different discussion, so that's number one. The second reason for DBS failure is improper placement. The target, as I said, the subthalamic nucleus, is the size of an almond. Basically, if you don't hit that right on the nose, then you're not going to get the results, and you're going to get potentially side effects. So that's why it's critical that your team knows what they're doing and gets it in the right spot. The third reason for DBS failure is, post-operatively, it's really up to the the movement disorder doctor to manage the DBS settings and the simulation, the electricity, as well as the chemistry. So we're balancing chemistry and electricity. And if programming of the DBS device isn't done with a knowledgeable person, then you're not going to get the results. But that's outweighed by the first two. Shouldn't have never had it done, or it's in the wrong spot. There is a window of opportunity. Don't save it till it's too late. One of my slides was what we call the Hone and Yar staging system. I already talked about the unified Parkinson's system. The Hone and Yar, or HY scale, is kind of a clinical global stage from 1 to 5. And you don't need it when you're a 1. If you wait till you're a 5, it's not going to work. It's too late. We want to catch you between 2 and 4, and preferably between 2 and 3. Because we now know that the sooner you get it done, the better the results. And there was a study out of the Stanford folks about 2-3 years ago that showed that people who had DBS done, their rate of progression down the road was lower, was better. They didn't progress to the same extent as much. So it may actually have a disease modifying aspect, which would be great. But you need to get it done when you've got that golden window of opportunity. I can tell you when that is. Why is a person not a candidate if they have cognitive impairment? And the reason is a couple of things. One is patients need to be interactive on the operating room table. The procedure itself, bear in mind, when I first got involved with this, it was an all-day thing. It was like 6 to 8 to 12 hours. I mean, it was a long procedure because, as a field, it was just in its infancy. Now we get it done within usually 60 to 90 minutes, an hour or two in the operating room. But still, the procedure is you come in the morning, you get a halo, a head frame put on, you go to the operating room, the anesthesiologist turns on the juice, and it's actually a quick-acting anesthetic, like propofol, and it's quick, it puts you to sleep. The surgeon drills the hole, and then we wake the patient up, and I'm interacting with the patient. So he or she and I have to be talking and conversant. If a person has some dementia, they may not be with it. They may not be as cognitively aware, or they need to be able to tell me, are you feeling anything? If I'm testing the device, I need to know, is your hand tingling? Is your face, are you having any kind of whatever? So that's one reason. A person with dementia may not hang in there during that procedure. The second reason is, bigger picture, it just doesn't work as well. And the reason for that is not really entirely known. So basically, we will allow for a certain amount of, we all get some short-term memory stuff. That's okay. But if you crossed over into the dementia realm, then it's better not. I have a couple of patients right now as we speak. In fact, the first patient we did, a lady in Ventura, she's still on basically no meds. And that was 2 years ago. Was that 2 or 3 years ago? It's been a couple of years. And but I don't tell people to expect no meds. It's just less meds, for sure. For sure, less meds. Your eyes, how does Parkinson's affect your eyes? Not much. The vision is usually, the quick answer is Parkinson's does not affect vision. The longer answer is a couple of things. One is Parkinson patients have been found on studies to have some impairment of contrast sensitivity, so that things like edges or structure, sort of the boundaries, they may not have as good of an awareness of edges or contrast sensitivity. The other thing is, oddly, the retina produces dopamine. And in fact, going back 15, 20, 30 years, a neurologist at Emory in Atlanta, Ray Watts, was using retinal pigmented epithelial cells, and he would wrap them around microspheres, and he was injecting those, and it worked. But as far as vision, again, the other way that Parkinson's can affect vision is something called convergence insufficiency. So normally when we're looking at somebody up close, and then I want to look at somebody back there, there's an automatic adjustment that your iris and your lens makes, and that may not happen. So blurred vision, double vision can occur. Some people need prisms in their glasses to get their eyes to fuse. But vision things do not respond to dopamine. Yeah, the logistics of deep brain stimulation is it's 3 stages. We do 1 implant, you go home the next day. 2 weeks later, we do the other implant, you go home the next day. 2 weeks later, you come back as an outpatient and get your battery put in. And we usually use 1 battery per side. They do make a battery that powers both sides, but we prefer the one on both sides. And then, so once your batteries are in, usually when a patient comes in a week later for their check on their stitches, on their battery, I will do some initial, very slight programming a week later. But usually it's a process which usually after a couple of visits, and I see patients every 2 to 4 weeks, usually after a couple of visits of kind of tinkering and fine-tuning, we get things settled in after a month or 2.
Scientific, one of the manufacturers that they use.
There are 3 manufacturers. Boston Scientific is one, Medtronic is the other, Abbott is the other. We prefer the Abbott system. We think it offers the most capabilities, but they're all quite similar. Well, you get one of these on one side. 2 weeks later, you get the other side. 2 weeks later, you get your battery. Thank you.